All right, we'll go ahead and get started with public comment, and hopefully Assemblywoman Thomas can get in before we get to the actual business. Well, again, good morning, everybody. Thanks to you all for coming today. We have a pretty packed agenda. I actually have an annotated one here that's going to try to keep us on a particular time frame, including 9 minutes for public comment. We'll see how it goes. For public comment, agenda item number 2, we are now there. It's going to be limited to 3 minutes per person. We'll begin with comments from Las Vegas and then invite comments from Carson City, followed by virtual participants. If you are in person, please form a line. And before commenting, please state your full name for the record. Can you advance the slide, please? Oh, okay. All right. And if you're attending virtually, if you're dialing in from a telephone, dial 719-359-4580. And when prompted, enter the webinar ID number 841-1615-6896. And the meeting passcode is 676835. Please press *9 so the host can prompt you to unmute. If you're joining virtually with computer audio, please use the raise hand feature to indicate you'd like to provide public comment so the host can prompt you to unmute. And before commenting, please state your full name for the record. And also comments can be emailed to lhale@socialent.com. And these comments and questions will be recorded in the meeting minutes. And with that, do we have anyone present in Vegas for public comment? Go ahead.
Giuseppe Mandel, representing American Addiction Centers in Desert Hope, also a person in long-term recovery. And I thank you all for allowing me to sit in your meeting and learn.
Absolutely. Thank you. And welcome back. Okay. No others here. Do we have any public comment? Do we have Carson City? In Carson City?
No public comment in Carson City.
All right. Any other? Okay. All right. Do we have any public comment on the phones?
Sir, I did see Rick Wright did have his hand raised and now it's down. So okay. I'm just waiting to see if he raises it again.
All right.
Yes.
So I see none, hear none on the phone. Let's go ahead and go to on the screen here. Mr. Wright, go ahead.
Yes, this is Rick Wright, Impact Exchange, Track B Exchange, Las Vegas, Nevada. Just joining to listen in.
Great to have you back. Thank you so much for joining us. Is there anyone else for public comment in either format? Okay, hearing and seeing none, we are now ahead of schedule. And we'll move to agenda item number 3, which is a review and approval of the minutes from our July 12th, 2023 SURG meeting for possible action. They have been distributed. Let me open it up for any particular suggestions on corrections of the minutes. Do we have anyone who wants to suggest corrections for the minutes? If not, then I will entertain a motion to approve the minutes.
Debbie Nadler, for the record, make a motion that we approve the minutes for July 12th.
Thanks, Debbie. Could I get a second?
Good morning, this is Jeff Iverson.
Was that a second, Mr. Iverson?
Sure, I will second that motion.
Thanks, Jeff, and welcome to the meeting, sir. We got you listed here as present now. It has been moved and properly seconded. Thank you. That we approve the minutes from our July 12, 2023 meeting. Any discussion on the matter? Hearing and seeing none, all in favor say aye. Aye.
Aye.
Aye.
Aye. Aye.
Any opposed, say nay. Any abstentions? All right, motion carries unanimously. Thank you so much. We will move on to agenda item number 4, which is an update from SURG to SURG membership. We have allotted 5 minutes for this, and we will begin with appointment of new SURG members. The first of which is Nancy Linder, the Executive Director of Ridge House, to serve the remaining term as a person who provides services related to the treatment of substance use disorders. And we also have Dr. Beth Slemowitz, Pharmacy Policy Advisor with the Department of Health and Human Services, to serve the remaining term as the appointee of the Director of the Department of Health and Human Services. Do I need to take these one at a time? Can I take them as a group?
You can always take them to a group.
All right, then I will And then I will take the next bullet point in a second. I will take a motion to, do I have to?
You're
Just
the
a motion?
appointing.
So I'm appointed.
Yeah,
You are hereby appointed. There we go. Okay, welcome to the committee, Ms. Linder and Dr. Slamowitz. We appreciate your time and dedication to this, and we look forward to working with you. So welcome to the committee. We're gonna have a pending change for a particular seat. We're gonna need one representative of a local governmental entity that provides or oversees the provision of human services in a county whose population is 100,000 or more, but less than 700,000. This seat is currently being held by our vice chair, Lisa Lee, and I am not pleased to announce that she will not be able to serve on our committee in that capacity, nor as our vice chair. So before I announce the appointment for that position, I just want to say, Lisa, say something so I can see you on the screen. I want to look you right in your face while I talk to you. Say something, Lisa.
Good morning, Attorney General Ford.
There you are. I wanted to look at you and you can maybe see me looking at you. Thank you. You've been a great addition to this. I get goosebumps thinking about it because you are one of the most committed persons that I've seen working in this area. Your expertise is unsurpassed and your dedication to what we are doing here is worth noting. And we're certainly going to miss it in an official capacity as vice chair of this organization, but also as chair of one of our subcommittees. Your input is just absolutely incredible. And so I want to say thank you on behalf of the entire committee for your service and your work to us. And we wish you well and Godspeed in whatever your next endeavors are. With that, I want you to know you're not getting off the hook though. I actually get to request folks to serve as experts and participate in these meetings, albeit as non-voting members, and I'll be introducing someone who fits that bill in just a second. And I would ask that you please consider staying on in an expert kind of capacity and be able to provide us input, resources, and whatnot. So hopefully you will. I saw your thumbs up. Hopefully that means
Yes.
you will accept that invitation. And so thank you so much, Lisa. Do you want to say anything, Lisa, before I move on?
Yes, I would. Thank you so much for that that offer. This is probably the hardest decision of making the decision to leave the county is the surge. And I just want to thank all of you. I want to look at your beautiful faces for a moment in your box. I know a lot of you, in real life. And I just want to commend each and every one of you for your dedication, especially the folks that I've grown so close to on the treatment and recovery subcommittee. I just admire you all so much and what you bring to the table. And so I would love to continue to serve in whatever capacity I'm able to in the future. I'm going to get this dissertation completed and come back to it. Thank you.
Well, soon to be Dr. Lee, again, we appreciate all your work and we look forward to having you serve in your volunteer capacity. So, all right, with that, then I will move to announce the appointment, and that's going to be Dorothy Edwards. Dorothy, are you here?
Yes, sir, I'm here. And boy, that's hard shoes to fill.
Yeah, well, Dorothy, we appreciate you filling those shoes. This is an important committee. We do important work, and we're happy to have you join us. And so welcome to the committee. You are likewise hereby appointed for that particular capacity. So thank you so much.
She'll be appointed. Lisa's going to October 13th.
All right, so your appointment is pending Lisa's departure October 13th. I want to be clear about that. Okay? All right, thank you so much. Am I good?
Mhm.
Okay, all right, then we will move on then to agenda item number 5. You know what, before I leave, let me ask, is there anyone who wants to say any words under this agenda item before I introduce one other person? Okay, we have also been connected with, and we're grateful to be connected with, the DA from Persian County, Bryce Shields, who is not an official member of the committee, but one of those experts that I've talked about. It's important for us to get, as you all know, from my perspective, as many different perspectives on these issues as possible. And so from a law enforcement perspective, from a district attorney's perspective, who engages with this issue on a probably daily basis, but certainly very frequently, the Nevada District Attorneys Association has requested that Mr. Shields serve as its representative in an expert capacity for us. And so I'd like to introduce him to everyone. And Mr. Shields, or DA Shields, if you'd like to say a couple of words, introduce yourself, that'd be appropriate.
Thank you, AG Ford. I appreciate the opportunity to serve on this committee. I read over the statute that was passed in 2021, putting this important work together, and I look forward to contributing in any way that I can. So thank you very much.
Thanks, DA. We look forward to your participation, man. Thank you so much. Appreciate it. Okay, that it for this agenda item? We will move on then to agenda item number 5, which is a review and refinement of the scoring tools and processes for possible action. To discuss this, I'm going to tender the mic to Laura Hale of Social Entrepreneurs. We've allotted 5 minutes for this discussion, and items 7 and 8, to be clear, are contingent upon approval of this process. And so with that, Ms. Hale, the mic's yours.
Thank you, Chair Ford. So I just wanted to review a little bit of the background. Last year at this time, the SURG recommendations were weighted by the subcommittees at that level, and then they pushed forward their recommendations, their top recommendations, to the larger SURG, and then those were aggregated. And then at the SURG meeting, each recommendation was voted on for inclusion in the annual report. And as in this year, we're looking for up to 20 recommendations, so same as last year. We got some feedback from the SURG members following the annual report and the whole process we did last year. And one of those things was to have a more qualitative review at the subcommittee level rather than doing the ranking at that level. And then there was also feedback to reflect the level of overall support for the recommendations at the full SURG level. So we had brought forward a proposal in July, some of you may recall, to incorporate that qualitative review and then do a ranking process with this full SURG. So there were subcommittee meetings in July, August, and also in September. And those qualitative reviews were held, and members looked at impact, urgency, capacity, and equity for every single recommendation, and kind of looked at how a particular recommendation met all of those different qualitative considerations. So then individual members were responsible for sponsoring those recommendations and providing information and different resources linked to them. And then following those deliberations in the subcommittee based on those presentations, the top 5 to 10 recommendations would be automatically weighted. So I'm sorry, the top 5 to 10 recommendations were approved by the subcommittees to move forward to what we're doing today. So today we'll have the subcommittee chairs or their appointees presenting those top recommendations and also giving you some background on those qualitative reviews so that the full SURG membership can understand how those recommendations got moved up to this meeting today. What we're proposing to do in terms of the ranking is to use the Slido tool, which I think some of you are familiar with. And what it does is it will automatically aggregate. So each member is going to have an opportunity, if this is approved, each member is going to have an opportunity to rank their top 5 recommendations using the Slido tool, and then the Slido will automatically aggregate that based on all the entries and come up with the top 20 based on that. Then what we'd like to do afterward is have, based on those top 20 results, you all will have a discussion facilitated by Chair Ford to do one of four things. The first option would be to move recommendations forward to include in the annual report. The second could be remand a recommendation back to the subcommittee, and that could be, like last year, there were some recommendations that were similar, and so those got merged, or some of the members might be hearing some of the details for the first time today, so they might have some input that would need to go back to the subcommittee. So that'll be a possibility. The third option would be to assign it for future action. So there may be something that you want to say, let's move this forward to 2024 and go back through the full subcommittee process later. The fourth option would be to assign no further action. So for example, there might be a recommendation that is being taken care of through another entity. It could be a county or an agency, just based on changes that occur through the year. So you might say, well, the SURG really doesn't need to continue to work on that particular recommendation. So those are broadly what we would see as the options, and you could possibly do a consent agenda for the items that are the first option, which would be move those forward to December. That doesn't mean that it is the final determination for what those top 20 recommendations will be to include in the annual report. It's just kind of a preliminary. At this point in time, we're ready to move that forward to January. We don't need to do further work on it December. We don't need to do further work on it through the subcommittees. So that's basically what we're proposing. And then there's a little description of how the weighting works in Slido, and it varies depending on the number of participants that are actually using the tool. But, there's just an example there. So when you are ranking, and Crystal is going to take you through the actual Slido process if this proposal meets with your approval. If there are any questions that members have, I'd be happy to try to answer them, but this is generally what we're hoping to do today.
All right, thanks for that review, Laura. Let me open it up to the body for questions, concerns, complaints, considerations. Any questions? All right, hearing none, then this is for possible action. I think I need to take a motion to approve the refinement of our scoring tool and process. And so I will entertain a motion to do so.
This is Jeff Iverson. I'd love to motion to approve.
Thank you. Can I get a second?
This is Lisa Lee, and I will second that motion to approve.
Thank you. So moving and properly seconded that we accept the refinement of our scoring tool and process. Any discussion on this matter? Hearing, seeing none, all in favor say aye. Aye.
Aye.
Aye.
Aye.
Any opposed say nay. Any abstentions? Motion carries unanimously. Thank you again, Laura. We appreciate that. And we will move on then to agenda item number 6, which are subcommittee reports and recommendations. These are likewise for possible action from harm reduction, prevention. Is Jessica Johnson here?
Yes, sir.
Oh, okay. Prevention, treatment and recovery and response. Members are going to be invited to ask questions and or suggest changes to recommendations following each subcommittee report. And we've allotted 18 minutes per subcommittee to report on this. Not that you have to take all 18 minutes, but you have up to 18 minutes. And with that, Jessica Johnson, would you please proceed with discussing the harm reduction reports and recommendations?
Wonderful. Good morning, everyone. Thank you, Attorney General Ford and the SURG committee. Hopefully you can hear me okay. I have been having some tech issues this morning and tech is currently winning. So hopefully things are coming through on my end. I'm here today as your prevention subcommittee chair. So as many of you know from our meeting in July, the SURG prevention subcommittee has been taking on not only the prevention recommendations, but also workshopping on behalf of the larger SURG, these harm reduction recommendations. So today I'm going to present these to you, and then my vice chair, Eric Schoen, will be presenting the prevention subcommittee recommendations. The first two recommendations that we have here today. So my plan, sorry, is to just review the workshop recommendations, and then where we have that qualitative information, summarize that for the committee. Just checking with SEI staff to ensure there's no other information that would be helpful or valuable for consideration.
Jessica, this is Kelly Marshall for the record. So just, it was noted on the previous slide, but everybody should have, and it was posted as a public document, the SURG combined recommendations for October 2023. That handout provides the full narrative with justification for every recommendation. So our recommendation is that SURG committee members and the public at large use that so that they have the full breadth of the work that's been done by the subcommittee.
Thank you, Kelly, Jessica Johnson for the record. So in my presentation today, I'll just be referring to the pages which are also on here and summarizing some of the qualitative information. Our subcommittee did take on the bulk of preparing the qualitative recommendation for these harm reduction recommendations on top of the prevention qualitative recommendations. However, we did not have the opportunity to prepare them for this first and second recommendations that you see on the screen. So if time allots, Chair, and the committee would like to discuss these various qualitative components for the community drug checking, a statewide initiative for community drug checking, and harm reduction shipping supply, I'd be happy to do that under your guidance.
Very well, thank you.
Wonderful. So our first proposal for this recommendation is to establish a statewide initiative for community drug checking that incorporates qualitative and quantitative drug checking and includes the parameters outlined on this slide. And then for harm reduction number 2, our recommendation is to provide travel costs for pickup of used harm reduction products to be returned for destruction, increasing advertising about shipping programs statewide, and establishing an alternative strategy for individuals who aren't able to receive delivery of supplies for some of our more rural and frontier areas. We do have qualitative recommendation information for the other 3 harm reduction recommendations. So I'm going to go ahead and move on to the following pages here. So harm reduction number 3, sorry, let me get my notes in order here, is around increasing support for harm reduction based post overdose outreach in partnership with public safety, and this includes wraparound services for family members and post-mortem services for families in this regard. Our committee had discussed at length the urgency around this is that post-overdose response teams do provide timely service to people who are in the midst of overdose crisis. From an impact perspective, this supports particularly individuals who are vulnerable to overdose, an opportunity to connect to services and care. And from a family member perspective, there are a lot of impacts in this time of post-overdose when there's a fatal overdose. My committee member, Ms. Nadler, prepared many reasons of how this impact can be so large for grieving family members and sort of the ripple effect that can happen when there's a fatal and non-fatal overdose for families. From a capacity and feasibility of implementation perspective, for harm reduction recommendation number 3, we know that many areas of the state have begun these types of interventions and established opportunities to connect people to care. And from a racial and health equity perspective, from our review of the literature on the subcommittee, it seems like there's an opportunity to better evaluate how these programs can be utilized to reduce health disparities and improve racial and health equity. So that's my summary for harm reduction recommendation number 3. If appropriate, I'd like to move on to number 4.
Yeah, why don't you go
So-
ahead and we can finish these up and we'll circle back if people have questions about particular ones.
Terrific. Thank you, Chair. So harm reduction recommendation number 4 is to create a bill draft request at the legislature to change language around drug paraphernalia as it relates to smoking supplies. From an impact perspective, studies have found that people who use or who inject drugs are often willing to switch to smoking or other types of modalities of administration when those things are feasible, and that these non-injection routes of administration can pose less of a risk for overdose. Many of the harms related to injection drug use, such as endocarditis, skin infections, vein damage, are injection specific, and that expansion of access to these supplies for public health purposes are additionally important for reducing risk for exposure to things like tuberculosis or COVID-19. From an impact, capacity and feasibility of implementation, Nevada already has multiple laws and policies that support access to harm reduction services, such as syringe services programs and reduced drug paraphernalia for things like drug checking equipment for personal overdose prevention. So making safer smoking equipment more widely available in partnership with harm reduction programs can provide more opportunities for this effective health communication and reduce healthcare barriers. From an urgency perspective, we know that fentanyl is rapidly becoming a primary opioid in the illicit drug supply and is often smoked rather than injected. And this is a growing urgency in our state and in our neighboring states. And this strategy of supporting access to safer smoking supplies can help increase health services for folks who otherwise might not be connected to syringe services or harm reduction programs already. From improving health equity perspective, harm reduction services for people who use drugs are most often entirely focused on injection. So access to safer smoking supplies create safer use options for people who don't inject, and oftentimes for folks who prefer stimulants as their primary drug. As we know from the data on the adulteration of the drug supply, it's important that we identify really broad strategies in this regard. Harm reduction programs can also connect people who smoke drugs to a wider array of harm reduction education, materials, access to care, and treatment if that's part of their plan. And engaging, there's some evidence that says that engaging people, that access to safer smoking supplies will engage people who smoke drugs, which can often be a younger population, and reduce the development or escalation or transition into injection for individuals. For harm reduction recommendation number 5, this is to provide support to community coalitions to support community health workers and expand harm reduction throughout the state of Nevada, prioritizing funding for CHWs to provide community-based harm reduction services. The impact for harm reduction number 5 was rated as high. There were a contender for most impactful strategy. colleagues on the prevention subcommittee felt that with respect to workforce development, that the widespread utilization of community health workers and peers and prevention specialists would really be at the top of the list. So identifying ways for paraprofessionals to engage in these are easily deployable to engage in these primary services for folks in the community. And really mobilizing these types of professions across our state, help Nevadans with supports that they need to mitigate any harm from possible substance use, including harm reduction efforts. From a capacity and feasibility of implementation perspective, the good news is that many of the community coalitions throughout Nevada are already utilizing CHWs in harm reduction efforts like naloxone training and distribution and other strategies. And these coalitions have done hard work of helping communities that they serve be more receptive to the importance of considering the science and utilizing harm reduction strategies. From an urgency perspective, this was rated as high. We know that time is of the essence for many of these harm reduction recommendations, and bringing these benefits to Nevada residents. From a enhancing health equity perspective, the use of paraprofessionals helps to promote diversity within the workforce. And they're uniquely positioned to be able to have an outsized positive influence relative to perhaps more traditional professions across the state. Chair, those are the impact and other qualitative items that we've prepared for these harm reduction recommendations today. I'd be happy to take any questions.
Thank you, Jennifer. So, Jessica, I'm sorry. So, there's a question around number 4, creating a bill draft request at the legislature to change the language around drug paraphernalia. I'm not sure I understand the connection between that particular description of the request and what's listed as the description here. Are there particular words or phrases or what language are we suggesting that needs to change in our NRS?
Wonderful. Jessica Johnson for the record. Thank you so much for that question. There are perhaps individuals on this call who are more expert than myself at being able to more fully answer your question. My understanding is that it comes into play with the drug, with what is considered drug paraphernalia within the law specifically. But happy if there's a person with more experience around this on the call, I'd be happy to yield to their expertise.
Anyone want to jump in on that one or chime in?
Lisa Lee has her hand raised.
Miss Lisa, go ahead.
Thank you, AG Ford. Lisa Lee for the record. I actually had a different question, but I'll sort of address safe smoking supply distribution across the US. So a good person to talk to would be Shiloh Jama. He's the creator of the Hammer Pipe from Seattle, the People's Alliance, whatever it is. I can't remember. The organization he was formerly affiliated with, and now he's at SANE in Sacramento. So he really was the originator of the safe smoking materials, the education materials, because people were starting to utilize a less risky form of administration of their drugs, right? We can all agree that smoking is less harmful than injecting as far as soft tissue infections, even reducing overdose risk, etc. Not eliminating overdose risk, but reducing it marginally. And so he might be a good person to talk to. Mark Kinsley, of course, was the guy who created all of those materials, and sadly he passed away last July. So there are templates of language to pull on that, and harm reduction organizations have been distributing safe smoking supplies and education for a long time. Those materials exist. So I'll just leave it at that. And then I had a separate question. Is it okay to ask that now, Chair Ford?
Yeah, well, let me see if there's anyone else who wants to chime in on my question about particular language from a BDR. I just don't see the description as fitting what's the explanation is, but maybe it's just me. Is there anyone else who can speak to this? All right, if not, then I would take it offline and maybe we can try to get a better understanding personally. So go ahead with your question, Lisa.
Thank you, AG Ford. Lisa Lee for the record. I will just comment briefly about the transition to smoking. I can tell you that I am seeing that amongst local people who use drugs. There's been a lot of people who've dropped out of at least a weekly encounter with the syringe services program because they have shifted to smoking rather than injecting. And so there is a consistent trend, and it's been that way for a couple of years now. So I will say that. And then when you don't have contact with those folks, then you also don't have harm reduction education and contacts, et cetera, happening. So I will say that that's happening locally as well. I can't speak for Las Vegas. My question was regarding, and first of all, thank you, Jessica, for pushing forward these recommendations, and thank you to your committee. The harm reduction recommendation number 3, I love this. But I also wanted to add something that's sort of been at the forefront of my thinking around non-fatal overdose is the issue of hypoxic and anoxic brain injury as a result of a non-fatal overdose. It probably explains a lot about the way my own brain works, right? Is that people are going around with a form of brain injury. And I found some great resources. I just think that this could be sort of woven into a post-overdose response to really address maybe behavioral or cognitive changes that a loved one may be experiencing following a non-fatal overdose event. There is a great resource. There's a whole toolkit available that might be under consideration for your subcommittee to sort of take a look at and see if pieces of that could be, like I said, woven into some sort of post-overdose intervention. And it's from the NH Providers Association. If you just look up like anoxic brain injury overdose, this is how I came across it. I was trying to really get more information so to educate providers around this. And there's, like I said, there's some one-pagers. There's a whole toolkit. And I do believe that that needs to be addressed, and it's just not talked about. And it does have long-lasting impacts over the course of somebody's life. So just wanted to bring that up. Thank you again.
All right, thanks, Lisa. Any other comments, questions, concerns?
This is Chelsea Cheatham for the record. So I know that in Las Vegas at the harm reduction program that I've worked at, there would be an interest in, the bill draft request to change language around drug paraphernalia when it comes to smoking supplies, because I think harm reduction programs feel a little more comfortable giving out those supplies to people if it was written into law that those supplies couldn't be used against the clients that they're handing them out to as evidence of paraphernalia. And also there's some areas around supplies that are used for safe smoking that also have other commercial uses, and just making sure that it's just kind of clear that clients who are receiving those supplies from the harm reduction programs are getting them from a harm reduction program, and they're not able to be used as paraphernalia or evidence of paraphernalia against them.
Yeah, thank you for that input. I appreciate that. Anything else on this topic? All
Sure.
right, if not, I'm sorry, yeah, go ahead.
Oh, sorry, Chair Ford, Jessica Johnson for the record. If there are folks on this committee, if harm reduction recommendations 1 and 2 make it through on the Slido today, we will need some volunteers to populate the qualitative data for them. So I just wanted to bring that up. If folks who are on this call are willing to do that, that would be great for the workshopping for the subcommittee.
Okay, duly noted. Thank you so much. And Jessica, thank you for the presentation.
Thank you,
We'll
Chair.
move on then. Yeah, you got it. We'll move on to the next one, which is prevention. And I believe Mr. Schoen is going to be presenting that one. So, sir, mic's yours.
Yes, good morning, everybody. Eric Schoen, for the record. I currently serve as a vice chair for the prevention subcommittee. Can you all hear me? Yes, okay, perfect.
Yes.
So I have a batch of prevention subcommittee recommendations here for
You're breaking up, man.
to present to you, as well as 3 additional harm. Oh, sorry, I'm going to turn off my video. My feed might be a little bit weak. Okay, hopefully that's better. Is that better?
It is.
For the moment? Okay. So I will take these in groups and try to provide a through line for our rationale for these 4 different recommendations. And if there's a through line, before I get into the specifics of these, I think it would be hard to find a more passionate group of subcommittee members who believe in the power of stage 0 interventions. That is basically prevention before there is any sort of harm done from a potential use of any particular substance or from any mental health issues or what have you. And recognizing that historically, we have probably underfunded prevention relative to other strategies. We are seeing a lot of good research across the country that supports investing in what's being called a health and wellness approach versus a medical approach to providing services around these issues. And so there's a through line. I would say that's one of the main through lines for these recommendations. With that being said, there's other through lines too, but with that being said, let's get into the specific recommendations. Our first recommendation is to recommend to DHHS, DPPH, the Bureau of Behavioral Health Wellness Prevention, to double the amount of investment in primary prevention programming every 2 years for ages 0 to 24 and review the funding allocations annually. You have on those various pages the different sort of arguments that have been put forward. We believe there's an urgency for each one of our recommendations. So I'm not necessarily going to go into those, but I do want to sort of talk a bit about why this is phrased in such a particular way. We didn't want there to be any hedge room for people for decision makers, for policymakers, for folks who are making the budgets to kind of be able to wiggle around how much can we increase this and get away with it. So we struck a hard target of double the amount. Well, that means we have to come up with a baseline number that we can double from. We had a wonderful presentation from folks who work at the state at our last prevention subcommittee meeting, and there are so many different sources of prevention funding, federal sources of funding, some state funding, some settlement funding, that when we tried to ask sort of a basic question, well, what's the amount of funding that is currently going to prevention? It was hard to come up with a number. So what we have to do is to make sure that we have a number of what this would mean. Is it 10 million a year? Is it 20 million a year currently? Is it 30 million a year? What's the number?
You're breaking up again, buddy.
Well, so I don't have Jessica. If Jessica is in a better position than I am.
Yeah, I think the question, Jessica, was if you could take it over because he's breaking up, at least on our end, he's breaking up pretty badly.
Sure. Thank you. So to just pick up where Vice Chair Schoen left off, Jessica Johnson for the record, our conceptualization for this first recommendation is really, we wanted to be clear on the primary prevention programming for every 2 years. We're still working with the Bureau to identify the specific investment dollar amount in what is currently allocated for these age groups for primary prevention. So that's why there's not at our July prevention or at our July surge meeting, it was recommended for a follow-up presentation with the Bureau, and we did receive that at our last surge prevention subcommittee meeting. So we're working to determine the exact amount that's included here for the double the amount. But presently our recommendation is around doubling the amount of this investment in primary prevention programming for this younger age range of Nevadans, and to review these funding allocations annually to ensure that we are creating reach among our young people across the state, and that saturation or penetration across all groups. Mr. Schoen, would you like me to take the other recommendations as well?
If you wouldn't mind taking the next one, I'm actually moving to a different room in my house, which should be better, but I'm not quite set up yet.
Sure thing. Thanks for doing that. Teamwork makes the dream work on all of these areas. So our prevention subcommittee recommendation number 2. So Chair Ford, we really took your call to action from earlier this year to heart, recognizing that the surge does cover, a broad array of substances and prevention, treatment, recovery, harm reduction work across the board. So prevention subcommittee recommendation number 2 is around allocating tobacco control and prevention funding using local lead agencies model to reach a $2 per capita recommended funding, using a combination of funding sources that we have listed here on the slide. We were made aware by the Nevada Tobacco Coalition and other groups around some of the challenges that those groups have had with funding, particularly around some of their work with vaping and vaping prevention. And so really this strategy is to help ensure the continuity of those programmings and efforts across the state. And they have seen reduction in populations where they have provided this type of education, particularly for vaping, but also around combustible tobacco and other types of populations in the past. So we received some really great information about the impact that these programs have had, but are currently not able to scale up because of changes in funding.
I am back. I can take over now if you'd like to. Or if
Wonderful. Back to you,
Yeah.
Mr.
Right.
Schoen.
Thank you, Prevention Chair Johnson, for stepping in at a moment's notice. I would just add that the recommendation here by the CDC is $30 million a year for tobacco control funding for Nevada. And if we were to assess a $2 per capita recommended funding model, we would be at 6 million, which is only a fraction of the 30 million, but it would raise us from 47th to about 25th in terms of state rankings for addressing this very important issue. And we, as a prevention subcommittee, have the caveat added that we do not want this to cannibalize any prevention funding. So this would be above and beyond any funds that were allocated for tobacco control and prevention funding would be above and beyond, not at the expense of current prevention efforts. It's really, really important for me to stress that. The third recommendation is to Department of Health and Human Services, Office of Analytics, or the appropriate entity, to create a data dashboard or other type of regularly updated report on alcohol outlet, tobacco outlet, cannabis outlets density. There is research, as indicated in the additional pages you have, that highlights that those areas that have higher density tend to have higher uses of those substances. Not a surprise. and tend to have more problems associated with that. We don't currently have any tool like this, which seems kind of like having a toolbox and not having a hammer. It's an important tool. It could help us to better inform our policy decisions, our resources, our allocation of resources. And so our recommendation is to create some sort of data dashboard that would provide this kind of information. And then finally, for the prevention subcommittee recommendations, not including the additional harm reduction ones that we'll get into in just a second, expand Medicaid billing opportunities for prevention services and allow blending and braided funding to facilitate services to expand access to care for youth and adults. This is really moving squarely to the place where we believe that investing in stage 0, stage 1 interventions will have a huge impact dollar for dollar. We have an asset throughout the state that is does amazing things, and they continue to develop their infrastructure. That's prevention coalition infrastructure. They are really investing, showing us how to use community health workers across the state, really showing us how to also incorporate peers as part of that as well. And so we would really like to build on that infrastructure, and by having Medicaid allowed to bill for preventative services would help to provide some sustainability for these coalitions if they were the primary deliverer of such services. But anybody would help to provide some sustainability and not just to rely on an annual allocation of grant dollars. I will stop there before going into the next page to see if there's any questions on those first 4 recommendations or any comments.
Thanks, Eric. Are there any questions that people have of these first 4? So I do have a question about the first. I understand the rationale behind setting kind of a, for lack of a better phrase, dollar figure by saying you want them to double the amount. A question I would imagine coming up is what metric, however, are you using to determine that that is an amount that is sufficient to address a particular issue?
Chairman Ford, I think that Eric's shown for the record, I think that's a fair question. We too are trying to get, well, so to your point, you're right. It may not be sufficient for whatever particular issue. I guess the counter argument is what we're doing right now is probably not near sufficient as well. I think what we were trying to do in making such a recommendation is trying to drive some accountability around the budget making process, because it seems to me over the couple of decades that I've been doing this work here in Nevada that oftentimes there's a lot of talk, if you will, about prevention being important, but then when dollars have to meet the road, if you will, prevention tends to be shortchanged. And so the hope would be that by providing such a stringent target, it would hopefully drive some accountability in the budget making process.
No, listen, I appreciate that and I understand the rationale behind it. I'm just putting myself in the place of a legislator, either in the interim IFC or in the budget committee, making the decisions on how we're going to spend general fund monies or even opioid money for this matter, right? Because it's going to the opioid folks. The question would be what I would imagine, what studies, what data, what details, what facts do you have that indicate that any particular amount of money would be sufficient to do something in particular? I'm not suggesting that double amount would not be enough. What if it's way too much and we're just sitting on cash and not being able to utilize it and it's being wasted by sitting in an account that could be utilized elsewhere? So I would just suggest that the subcommittee and others on this committee consider a way to utilize some quantitative approach to requesting double or any amount of investment in primary prevention and to be able to track that with maybe elsewhere we've demonstrated that $100 is enough to educate 5 people. I'm making this number up, right? So when you ask for a multiple of 100, you'll be touching a multiple of 5. Am I making sense?
Yeah, you are.
Yeah, okay. So that was just a thought and a question I had in that regard. I appreciate what Jessica Johnson said about this committee being more than just about opioids and looking at the tobacco stuff here. I think we would certainly have to look at the master service agreement to ensure that we can do some of the things you're talking about here. But I do appreciate the approach to this as being more than just opioid related stuff. So those are the questions or comments that I had in that regard. Any other questions, comments? All right, hearing none, then go ahead with your last two. I think they're last two. Right?
Excuse me, I'm sorry.
Hands raised.
My hand was
Sorry,
raised.
all right, go ahead, Debbie. I didn't see your hand. I'm sorry.
I'm sorry. Thank you, Attorney General, for highlighting the number one recommendation. Yeah, it's really hard to put a number on how much dollars are needed, but we do know at this point we are losing more and more young kids. I mean, starting at the age of 10. And I was thinking perhaps maybe if it's okay with Jessica, Eric, and our prevention subcommittee, if perhaps we could have a small meeting to address number one, maybe break it down further to show why and what's being used, because I do know in Reno, the research I've done is it seems to be a lot more education, such as the DARE programs being put back in the schools. There's just different things that are being allocated up north that are not being allocated down south. So perhaps we could have another meeting to discuss number one. It's so important.
Well, I'll say that is an option. I think one of the last things in terms of your options you have here is to send this back to committee for additional consideration. And if that's a discussion, if that's a decision that is made at the end of all of this, so be it. But thanks for your input on that, Debbie.
Thank you.
All right, Ms. Johnson.
Yeah.
Oh, I'm sorry. Hold on, Jessica, before you speak. Eric, were you going to say anything in response? My
Oh,
apologies.
no, I thought I was going on to the next recommendations, but if Jessica has more to comment on, please
Yeah.
do.
Yeah,
Go ahead,
thank you.
Jessica.
Thank you so much, Jessica Johnson, for the record. To your earlier question, Chair Ford, SAMHSA did do a cost benefit analysis of these types of prevention programs. We hesitated to really include any of that here because it is over 20 years old. So likely costs are slightly out of date. And looking at what some of those prevention targets are and the long-term impact, perhaps there's an opportunity for this committee to workshop this recommendation a little bit more effectively and add in an opportunity to study the cost effectiveness of these types of investments or programs. We do know this is a very long-term strategy, but there are, tangible benefits from these evidence-based primary prevention programs that are realized in communities over time. So that is something we could consider if that would help answer your question.
Listen, I appreciate that. You've articulated it a lot more eloquently than I could, and I appreciate that. We are coming up on our time frame, though, so we have to. Why don't you go ahead and summarize those last three, and we'll move on, okay?
Well, fortunately, these don't need much explanation because they kind of explain themselves. Eric Schoen, for the record, again, prevention chair, vice chair. So prevention subcommittee recommendation number 5, support harm reduction through making a recommendation to DHHS to utilize opioid settlement dollars to designate a baseline level of identification and overdose reversal medication for the next 10 years in Nevada, basis on the state naloxone saturation plan to create a stable, sustainable source of overdose reversal medication throughout the state. For those of us who do this work, it is we don't take it for granted being able to easily obtain naloxone through a number of sources right now that are available. And essentially, this is an important tool, I think, to continue to provide peace of mind for the public to know that they can find naloxone and they can find so easily. but also as this crisis develops and fentanyl is used more and more, making sure that we have naloxone easily available to reverse those overdoses. So that's essentially what this is getting at. Number 6, support harm reduction through creating a recommendation to the legislature model the Maryland STOP Act, which authorizes certain emergency medical service providers to dispense naloxone to individuals who receive treatment for a non-fatal drug overdose or are evaluated by a crisis evaluation team, and require certain community services programs, certain private and public entities, and hospitals to have a protocol to dispense naloxone to certain individuals free of charge under certain circumstances. Again, this is the idea of making sure that we have naloxone easily and readily available and easy to use when we need to have it available. And lastly, the support harm reduction through, this is number 7, implement changes to recruitment, retention, and compensation of health and behavioral health care workers and enhance compensation in alignment with the Commission on Behavioral Health Board's letter to the governor of June 22nd. Additionally, continue to sustain and expand investment community health workers, peer recovery specialists, and certified prevention specialists by implementing changes to recruitment, retention, and compensation. Prevention Chair Jessica Johnson talked about how important these up and coming professions are and what they contribute to this overall effort. And that's what this recommendation is suggesting, that we continue to invest in these important professions.
Very good. Thank you, Eric.
You're welcome.
I appreciate the presentation here. Very good. We will move on then to the next one, which is treatment and recovery. Vice Chair Lee, you can take it away.
Thank you, Chair Ford. Lisa Lee for the record. I'm the chair of the Treatment and Recovery Subcommittee, and I just wanted to thank all of our members for contributing to these recommendations, and I'm so pleased to present them today. The first one was from Dr. Dixon, and just a little caveat, we sort of separated them if it was a treatment recommendation or recovery support services recommendation, and if it had cross-cutting elements. And so this one is kind of in that treatment bucket with cross-cutting elements. And excuse me, it's a very long one. I apologize in advance. The recommendation is to expand access to medication-assisted treatment and recovery support for substance use disorders, limit barriers to individuals seeking treatment regardless of the ability to pay, and encourage the use of hub and spoke systems, as well as recovery support, including use and promotion of telehealth, considering the modifications that have been made under the emergency policies, and pursuing innovative programs such as establishing bridge MAT programs in emergency departments. And Dr. Dixon put this one, she said it needs to stay at the top of the list and that we still have a long way to go as far as getting people with an opioid use disorder into treatment. There are still barriers, including the cost associated with treatment. There were a bunch of folks who lost their Medicaid benefits. And so the suggestion was that some prescribers and facilities may need financial augmentation to be able to care for everyone, including maybe billing on a sliding fee scale or offering some sort of block grant funding to help pay for treatment. And Dr. Dixon, if I missed anything, please jump in. This was rated as urgent. And it was also rated the highest rating for impact. And then up for capacity to implement, it was rated kind of middle. The second recommendation is to implement follow-ups and referrals and linkage of care for justice-involved individuals, including individuals leaving the justice system. This is in the recovery supports bucket. And I do see that it has cross-cutting elements with one of the response subcommittee recommendations. And so we might want to take that into consideration as we move forward with the presentations today. Many individuals with substance use disorders end up in jail and prison, which aren't really great places if you want treatment and recovery support services. And so it was mentioned that Assembly Bill 156 of the 2023 legislative session attempted to mandate treatment, but the bill was changed instead to requiring studies and reports of all justice system entities regarding their data and treatment efforts. This is due June of 2024. Therefore, these reports should be used to design a new bill to again address the problem. Individuals should be inducted and treated in the jail and prison systems with continuity of care prior to and upon release. This was also rated as very urgent. It was rated as a large impact, and it was rated as a 1 on capacity to implement. So we might want to look at our capacity to implement such a recommendation in our justice system. The third recommendation is to implement a specialized child welfare service delivery model that will, with follow-up and referral and linkage to care, that improves outcomes for children and families affected by parental substance use and child maltreatment and pregnant or birthing persons with opioid use disorder. Looking at our data in the child welfare system and nationally, the trends are, it is trending that more and more children are placed into foster care because of parental substance use. This looks different across the state. I will say here in Washoe County, we tend to have a higher rate of removals, especially for infants than, and for all ages of children, but especially in the infant population, compared to Clark County and statewide. And so there are evidence-based models that specifically work to restore families if they are separated, or so it reduce the length of removal or stop the removal altogether by wrapping services around families. So this recommendation asks that. It also looks at pregnant and birthing persons with opioid use disorder and really prioritizing that population. This was rated as a 2 for urgency because it only affects pregnant and parenting people with substance use disorder. But I would also like to offer this, that when you look at overdose data, we're seeing that this is a common, that people of reproductive age are dying. I'll just put it in short form that way. People of reproductive age are dying in mass. And so, so we want to keep that in mind. Impact, this was rated the highest for impact due to the intergenerational breadth of the impact, as well as the impact on child welfare, schools, and juvenile and adult justice and treatment systems. When families recover, communities recover. It was rated a 2 for capacity to implement because child welfare is a notoriously difficult environment to retain staff. And much of the state is a treatment desert. So again, there are barriers to really tackling this. And then for advancing racial and health equity, this is huge. It was rated as a 3. We do see huge racial disparities in the child welfare system in Nevada and across the nation. The fourth recommendation is establish priority funding areas to ensure entry into treatment and or recovery, ensure that Black, Latinx, Hispanic, Indigenous, and people of color and LGBTQIA communities are receiving culturally and linguistically appropriate overdose prevention, such as naloxone, vending machines, and media, drug checking supplies to reduce fatal overdoses among Black, Latinx, Hispanic, Indigenous individuals, and people of color in Nevada. This was put forward and it kind of fits in that harm reduction bucket. It's put forward by Chelsea. And this is showing up, these disparities are showing up in our postmortem death data, right? We're seeing racial disparities. There's been papers published recently it's also, again, not just a Nevada trend, but it's nationwide that we're seeing racial disparities in overdoses. And so Black Wall Street gave a wonderful presentation about the work that they are doing to mitigate overdose deaths in underserved communities. This was rated a 3 for urgency because people are dying. It was rated a 3 on impact, and it was rated a 3 on capacity to implement, seeing as how we have willing agencies to do this work. And we'll move to the next slide, please. Recommendation number 5 is to significantly increase capacity, including access to treatment facilities and beds for intensive care coordination to facilitate transitions and to divert youth under the age of 18 at risk for higher level of care and/or system involvement. This goes in the treatment bucket, and it was brought forward by Vice Chair Steve. Sorry, reading through my notes here. It was rated a scale of 3 for urgency. As you all know, the Department of Justice put forward a scathing review. It was released in 2022, actually October 4th, 2022, really looking at our youth treatment systems across the state. And I know just from talking to lots of parents and working within this system that it's often out of state that we have to send youth and adolescents. And so this is a very urgent recommendation. Again, the impact, if you're looking at how to stop intergenerational cycles, this is where we do it. So again, rated 3 for impact and urgency, and rated a 2 for capacity to implement across the state. Also, additionally, to address racial and health equity, this ensures racial and health equity and eliminates existing barriers to treatment for youth. And recommendation number 6, engage individuals with living and lived experience in programming design considerations and enhance peer support for underserved populations to be delivered through representatives of underserved communities by increasing reimbursement rates, implementing train the trainer models, and enacting policy changes to address limitations to the use of peers in some settings through strategies, including ensure adequate funding for these priorities, target special populations, increase reimbursement rates, and offer standalone service provision opportunities. So this, it looks like, has cross-cutting elements with one of the recommendations from the prevention subcommittee. It is fine-tuned to peers specifically, and including that people with lived and living experience are creating the programs designed. It's usually the people closest to the problem that are also closest to the solution. And so this has been a gap in, designing interventions for a very long time. And this is a way for Nevada to really tackle that gap and make sure that the programs being designed meet the needs of the population being served. And these are a few of the strategies to get us there. It was ranked a 3 for urgency, a 2 for impact, and a 2 for capacity to implement. Given funding, there would be capacity to pay people with lived and living experiences, subject matter experts, pay peer recovery support specialists a living wage, which could be accomplished by increasing the reimbursement rates. They have not been increased since 2007, and expand peer recovery support services, train the trainer offerings across the state, especially to underrepresented communities. This would also include perspectives of impacted persons and to advance racial and health equity. And it would also create sensible and pragmatic solutions. And that's the conclusion of our recommendations from our subcommittee. I'm happy to answer any questions.
Thanks, Lisa. I appreciate that. We're going to open it up for questions. I will note for recommendation number 5, this is not to suggest you do nothing, but I want you to know whatever, if we do something in this arena, it's running parallel with the litigation you're talking about. And my office is engaged with the federal government around conversations to address some of this as well. So just kind of want you, that's about as much as I can say on it. Just want to let you all know about that. Number 6 reminds me of a conversation we had 2 cross-sector meetings ago. Cross-sector, is that what we call them? 2 cross-sectors meetings ago where I said we can kind of get moving on some PSAs that had peers involved in the design and whatnot. But I think I put the onus on folks to kind of organize and engage in the conversation around that, and I haven't heard back on it. So I'm just saying it out loud again. I can't remember exactly what we talked about, but I see Terry's head nodding right now. And so I'm still interested in having my office, work on that. We could move some of that stuff forward sooner than later. Let me back up now and see if there are any questions anyone has. I see a hand up. Debbie.
Thank you, Lisa. What a fabulous presentation. Thank you. You're spot on. If you could do me a favor and go back one screen, I had a question to ask you. I think it was number implement a special. Okay. Under number 3, is that the same thing as CPS, Child Protective Services? And the reason that I'm asking is because fortunately, my son's best friend right now, which I said before in the last meeting, he has an 8-year-old daughter, and CPS has been called out there and they're not doing anything. Is CPS required to do drug testing when they go out to a home? They get a report, the child's been missing from school. What extent do they get involved in then trying to enforce somebody or guide them, I'm sorry, it's my dog, into recovery or getting some kind of help?
Thank you, Debbie, for your question. So that's a very complex question. So child welfare, yes, it's CPS that I'm talking about, Child Protective Services. So there's a variety of safety factors. Drug use on its own, parental substance use on its own without any other safety factor is not reason to get involved and move towards an investigation. There would have to be other criteria met that jeopardize the safety of the child or children in the home for an investigation to be pushed forward. But I will say the child welfare system is really moving, and it's going to take a long time to pivot. But child welfare is moving from a reactive system, right? That is waiting for the crisis to happen, waiting for children to be in danger, to get involved. So this reactive system, we're going to wait and then react. It's pivoting towards a preventative system. And like I said, it's going to take a long time to kind of turn this big lumbering machine around. But through the Family First Prevention Services Act, that's really guidance on how to pivot towards a more preventative service model. And so it's getting involved before crisis happens. But unfortunately, the system as it is now does not have the capacity to really be proactive. So an ideal system, right, a prevention focused system would be getting involved with that family and providing services without opening an investigation. There are models such as the sobriety treatment and recovery team model that we're implementing here in Washoe County. It's been in existence since 1997 in Ohio. It's not new. It's evidence-based, and it pairs a peer recovery support specialist with the caseworker, and it operates on this really front-end heavy model that is very treatment and recovery support services focused right at the gate. And so not all of those cases have legal involvement. In other words, they're not always an investigation that requires removal of the child and placement into a kin or foster situation. And I'm probably just rambling at this point, and really, this is my topic, right? This is my dissertation topic. I'm really passionate about pregnant and parenting people and families. But I don't know if that answers your question. They're not required to really intervene unless an investigation, like the level of safety meets that level for investigation, if that makes sense.
It
Lisa, I
does. So
appreciate
it's
your
more-
response. Thanks.
Thank you, Lisa.
Yeah, Debbie, I'll have you take that offline with Lisa a little bit further. We'll miss your expertise and your knowledge. Obviously, you know what you're talking about here. I know we are at time, but I am going to allow one more question on this and then we'll move on. Dr. Kearns.
Yes, Lisa, thank you for your presentation. My question is on your first recommendation about the expanding access to MAT and recovery support services. We know that the DEA X waiver has changed, and we likely have a lot of providers within the state who could be providing these services. Is there anything in this recommendation that would address trying to, I guess, increase our pot of providers that are providing these services and kind of that outreach to those people who are currently aren't or are minimally doing these types of activities?
Dr. Kearns, thank you for your question. Lisa Lee for the record. I would actually like to offer space for Dr. Dixon, who is a subject matter expert on this topic, to answer that question, since I'm not a MAT provider.
Okay, she's not here, but we will duly noted, and Dr. Kearns will follow up with Dr. Dixon offline there. That's a perfect transition, though, to Dr. Kearns, who's going to be talking to us about response. And here's my intention. We're going to finish her out. We're going to take a break, and then we'll come back and finish the rest of this stuff. So, I mean, I know we need a break in between.
We need to vote first, I think.
I think we were going to try to review this. It will be very brief.
Okay. All right. So, okay. All right. Very well. Go ahead, Dr. Kearns.
Yes, thank
I just
you.
got trumped. So there you go.
Thank you, and appreciation to the response subcommittee for their work in bringing forth these recommendations. And as the other committee chairs have noted, many of their activities are on the beginning on the prevention spectrum, whereas the response is more at the end of the spectrum where people have already been taking drugs, had fatal or non-fatal overdoses. And I'll apologize for the first recommendation. It's rather long and wordy, but bear with me. Evaluate the current availability and readiness to provide comprehensive behavioral health services to include, but not limited to, screening, assessment, treatment, recovery support, and transitions for re-entry in local and state carceral facilities. Recommend the allocation of funding to support the development of a Medicaid re-entry section 1115 waiver to increase healthcare for people leaving carceral facilities and to support readiness of carceral facilities to implement the 1115 waiver. Recommend legislation to require the Department of Healthcare Financing and Policy to apply for and implement the 1115 waiver to increase healthcare for people leaving carceral facilities and ensure there is evaluation of readiness for planning and implementation. So I will say that I believe it was Lisa Lee who already talked about a report that is supposed to come out from DHHS in looking at our facilities, our carceral facilities, to see who is using MAT in their facilities, who doesn't have the capacity, and just their readiness for MAT first and foremost, and what they would need to do and able to have medication-assisted treatment programs in their facilities. So that is anticipated in June of 2024. It is an evidence-based strategy to use these types of programs. We had a very extensive presentation by DHCFP on the large program that they're already started to be able to apply for the 1115 waiver. And I should say this 1115 waiver would basically allow for anyone who would be leaving a carceral facility to have Medicaid 90 days prior to them leaving. So part of the problem has been that there's a gap once someone leaves a carceral facility in being able to, if they did have MAT started, in being able to continue that or counseling or any of those other services that are supported through Medicaid. So it would allow for that smooth transition with those services to individuals that would be leaving the carceral facilities. We thought that this on the urgency was a 2, which is mid. On the scale for impact, 3, the highest level, because as we know, oftentimes people who leave our carceral settings end up overdosing and or dying from overdoses because their tolerance is down, and if they try at the levels that they were at prior to incarceration. And then for the capacity to implement would be a 2, because a lot of work has already been done, but there's still a lot of work that has to be done in this area to be able to get this 1115 waiver in place. And from the health disparities of people who use drugs and those who are involved in our criminal justice system. So that's our first recommendation. Our second recommendation is understand the true cost of implementing wastewater-based epidemiology in Nevada and its ability to support community response plans. So what I will say is that we had a really great presentation from UNLV on their wastewater-based epidemiology program they've been doing. It's probably already widely known, this type of program that was used for COVID in trying to see where there were hotspots or areas where you were seeing increases in COVID. So the hope is to use the wastewater-based epidemiology to give us more data on what's going on, to look at hotspots, to look at additives, to look at areas we may be seeing increases in fentanyl, those types of things. And it's another data point in the data points that we already look at, and it's not real time, but depending on how it would be used, how it would be funded, it could be closer, because as we know, we often look at data from those who have died to find out what our drug supply is, and looking at the toxicology from their autopsies. And we feel like we could move closer to the point of overdoses occurring and drug use in our communities in order to get more data on this. So we looked at this as a 1 on the urgency, only because there's a lot of issues that need to be looked at, whether it's sewer systems, whether it's septics, those sorts of things, where it's already being used, where it would be implemented. 1 on urgency, again, because it's another data point in the data points that we currently do have, but would provide us additional data. And then the impact was a 3 that we saw that was high. And again, the health equity part of it is that it would really help to provide information on people who are using drugs. And it would give us that de-identifying data, aggregate types of data, but again, another data source. And I would just ask, I know Shayla Holmes is on the phone. This was your recommendation. If you have anything you'd like to add.
Thank you, Dr. Kern. Shayla Holmes for the record. I don't have too much more to add. You covered it pretty extensively. I do just want to highlight that this type of technology and data point would be broad, and that it's not just able to identify opioid use, but a variety of different types of chemicals and substances. And while, like Dr. Kearns mentioned, it's not real time, that is really dependent upon how it is implemented, which comes back to us needing to figure out the true cost of what this type of system could look like, because it is real time at the point of collection. So it does have the ability to provide very timely information and very specific to each community in which the wastewater samples are collected.
Thank you for that. Our third recommendation from the response subcommittee is again another lengthy one, but bear with me. Leverage existing programs and funding to develop outreach response providers and or personnel that can respond to any suspected overdose or to those who are provided treatment for an overdose in a hospital emergency room, EMS, and offer follow-up support, referrals, and services to the individual and loved ones following an overdose. Providers and or personnel to be deployed to anyone being released from institutional and community settings. Examples are hospitals, carceral facilities, and other institutional settings who is being discharged post-overdose or suspected overdose. Ensure this recommendation is included as the build out of Nevada's crisis response system is occurring so that tailored intervention for individuals who have survived a non-fatal overdose is continued. Again, this is a recommendation that from the implementation standpoint, there are already some teams that do exist in certain communities throughout. So we do have the implementation in some areas, but don't have anything in other areas. So some areas it would be easier to expand, other areas it would be more difficult. We would need to develop strategies for local, state, and federal law enforcement and public health agencies to respond to and prevent overdoses, plans for implementing those strategies. This is what we see as a more long-term solution. And the impact on this recommendation would be to provide support, wraparound services, and continuity of care for those who experience an overdose and who have contact with our institutions in our state. And as I mentioned already, not all places throughout the state have the capacity to implement these services, while some areas already do provide these. But we would suggest that this is provided as part of that crisis response plan, which is being worked on already in our state. Our next recommendation is recommendation number 4. Review the operations and lessons learned from Clark County's Overdose Fatality Review Task Force when that body's report is released in December of 2024, and take this into account when supporting legislation to establish regional overdose fatality review committees, allowing flexibility as to the makeup and practice, and for the OFR, overdose fatality review, to remain at the county or regional level as needed to effectively identify system gaps and innovative community-specific overdose prevention and intervention strategies in accordance with established best practices, such as the Bureau of Justice Assistance's Overdose Fatality Review, a practitioner's guide to implementation. What I would add is the Overdose Fatality Review was in this past legislative session, but did not pass, and the idea was to look at Clark County as kind of a pilot for overdose fatality reviews. We saw this on an urgency as a 3. On the scale for impact, it could be very impactful. And again, rather at looking at what happens once someone dies, but looking at areas where there are gaps where we could do outreach and prevention types of activities to prevent these overdoses and overdose deaths. And then also for the capacity to implement, that's mid-level, because again, it would need to see what the structure is. The county have the capacity to do this, or would it need to be done at a regional level? And a lot more information and study would need to be looked at what would be required to implement these programs. And as well with the health equities, again, looking at those who have suffered overdoses or have died from overdoses. They are an underrepresented group within our counties. Recommendation number 5, understand what coroners and medical examiners currently test for and make recommendation to a specific agency or other sources to fund personnel and resources for independent medical examiners for investigation and reports to specify the cause of death in overdose cases. this recommendation was brought forth by Christine Payson. And the idea of this is that it could affect many people within our communities from that health equity, such as veterans, elderly, people who are incarcerated, people who inject drugs, and others who are disproportionately impacted. Her suggestion is a potential bill draft request and expenditure of settlement funds, looking again at a long-term type of implementation. The urgency scale is a 2. The impact is a 2, which is mid-level, and then the capacity to implement this would be a 1. And one of the things that in our subcommittee meetings that we often heard is that in terms of knowing what the cause of death was, and even knowing all of the different substances that are in someone, there's a long and lengthy waiting time. So these could affect people who are in our criminal justice system as well, in terms of needing that information for possible prosecution. So there were numerous components to Christine's thoughts on recommendation number 5. Do we want to take questions or that, or move on to these recommendations that we move forward?
So let's take questions on this. Now, I want to understand what you're asking me though.
We are moving a couple of recommendations forward to the joint task force, so I was just going to highlight those.
Okay, that's on the same agenda item?
Yeah.
Okay, why don't you go ahead then?
Okay. The response subcommittee did take a couple of our recommendations and move those forward to the joint advisory task force, joint cross-sector advisory task force. And one of the recommendations that came forth from the response subcommittee from last year was to resolve the conflict between the Good Samaritan law and the drug-induced homicide law. And while we felt that we, at this point, may not have the capacity or full ability to resolve that conflict, there are some immediate things that could be done. And those immediate things that we referred to the joint task force to look at is to look at public health messaging best practices to educate the public on the Good Samaritan law and create targeted messaging of people who use drugs. And as well as not only the message, but the method by which that message would be delivered. And then also to provide education and training for law enforcement on the Good Samaritan law and drug-induced homicide law. The other recommendation that we move forward to the task force was to optimize available data to inform actions and update the community response plans. So just by way of background, years ago, probably about 5 years ago, our state implemented the overdose data mapping application program. And as part of that, through the advice of Dr. Woodard, was if we're going to have a program that was intended to identify spikes in overdoses in our communities, we should have some type of plan in place to be able to respond if we see those spikes in overdoses. So each one of the communities through the state opioid response grant wrote a community overdose spike response plan. Those were written. A couple of counties did exercise them through tabletop exercises or through a full scale exercise. But then, as we know, COVID hit and these plans got put on the shelf. So the recommendation to the joint task force is to really get the communities to take those plans off the shelves, dust them off and get them updated. Oftentimes people who are in positions who are named in those plans may not even be in those positions anymore. So that was the recommendation. And then also we, for further review, recommend for the response committee to investigate where inadequacies exist in the Good Samaritan law.
Okay. Thanks, Dr. Kearns. Let's open it up for questions on this this report.
Yeah, Debbie, Jessica, and Lisa.
All right, we'll go Debbie, Jessica, and Lisa.
Thank you so much. Great report. Can you go back one slide so I can remember the question? And it had to do with Tyler's Law. Are we doing quantitative and qualitative testing at this point? Do we have plans to do that? And when kids go to the hospital and hopefully do not have a fatal overdose, are they testing for fentanyl right now so that we know that's what they have in their system?
Yeah. Oh,
Go ahead, Dr. Kearns.
I was gonna say that's a great question, and unfortunately, within our state at this point, we do not have a law such as Tyler's Law, which is in California, which does require the testing of fentanyl when someone goes into a facility and has a overdose or suspected overdose. This particular recommendation looks at, unfortunately, as I mentioned before, after someone has already died of an overdose, has had a fatal overdose. So while your point is well taken, and that's a very important component in terms of looking at when someone comes in and has overdosed before they die, this one does not address that.
If I could ask a further question on that, I know many states do the quantitative and qualitative testing on the coroner's report. Do we have a plan of action? We'll be doing that, or is it too expensive, or just so we can see the amounts and what's in the system? Or, from my recollection, we don't have it in our state unless it was changed.
And in terms of from autopsies, when someone has died, they do a panel. That was one of the things, though, that we do need to find out is what is that panel that is done of drugs that are in someone's system. So that's something that we do need to investigate. There is a panel of drugs, but no one on our committee knew exactly what all was included in that panel of drugs. So we will need to investigate that further.
And as I understand it, some coroners test different panels of drugs. It's not consistent across the state. Just further to, are you shaking your head, Lisa? Am I wrong on that?
Thank you, AG Ford, Lisa Lee for the record. I can tell you up here in Washoe County, Dr. Knight is consistently checking for, and I'm going to say this wrong, I don't know how to say it, nitazines or nitazines. I don't know. When you read something, you never hear it. You don't know how to pronounce it, but and she also checks for mitragynine, which is an active chemical compound in kratom. So nitazines, mitragynine, fentanyl, and this has been consistent, but I don't know about other parts of the state and what those thresholds are. I think that's the question, is what's the threshold as far as micrograms go?
Yeah.
That is the question. Thank you, Lisa.
Okay. Who's the next person?
Jessica.
Jessica, go ahead.
Hi, thank you, Chair Ford, and excellent presentation, Dr. Kearns. I have a comment on 2 of the different response recommendations. I was thinking when you were presenting the recommendation number 3 that perhaps that aligned with the harm reduction recommendation number 3, or was wondering if the response subcommittee would consider workshopping the harm reduction number 3, response subcommittee recommendation number 3 into one more comprehensive sort of outreach response category, or what your thoughts are on that suggestion.
Yeah, thank you for that question. I had written that exact thing down in my notes, and I think that it would be encompassing. So I think this is one to workshop back between the response subcommittee and harm reduction.
Fantastic. And then I did have a follow-up comment for the response subcommittee recommendation number 5. Regarding the coroners, I would recommend the response subcommittee, if possible, request a presentation from the Clark County coroner, or perhaps whomever at the state is overseeing the overdose data to action funding. My brief knowledge around the types of funding panels are directly related to funds and funding caps that are specific to the different types of dollars that the state receives. And this is what dictates whether Coroners or medical examiners run a basic panel or an expanded panel for a suspected overdose death. Those stats are a lot of what we rely on, particularly in public health, for alerting the public or educating the public about what folks are dying from. And so I do think that not only what is being tested for, but an understanding of how these types of tests are funded and what some of the different funding caps might be would be very important for the expansion of this recommendation. Thank you.
Thank you for that recommendation.
Yeah, I don't know if there's a state coroners association or something like that, but if there is, maybe the presentation could expand beyond the Clark County coroner presentation, and you can ask more expansive questions on that. All right, thanks for that, Dr. Johnson. And then we had
Lisa Lee.
Lisa, go ahead.
Thank you, Chair Ford. Lisa Lee for the record. Just a quick question that raised, well, it's about number 5, recommendation number 5. So I definitely support coroners and medical examiners, like a kind of a universal standard across the state for checking drug-involved deaths. But what I had a question about is, Dr. Kearns, you said something about for prosecution, which kind of relates into that drug-induced homicide thing. And so I again asked the question, what are we doing here? Because if we're going to pursue messaging around educating people who use drugs and bystanders around Good Samaritan, the Good Samaritan Overdose Act, and also we're going to prosecute people that may, like, what are we doing? What is the intention of this, I guess? Because the way I saw the intention was for public health surveillance and to do better interventions, right? Because we know what's in the drug supply, we know it's showing up and potentially causing death across the state. So for those of us that are working, in harm reduction, that can be boots on the ground. How do we prevent deaths? But what I heard was prosecution. So I just need clarity and understanding before we move to voting about what the intention of this recommendation is. Thank you.
Certainly. And Christine Payson is not here today in the meeting, so I'll try to speak based on my understanding. As I mentioned, Christine Payson, who is our representative from the Nevada Sheriffs and Chiefs Association, brought this recommendation, and the intention when she brought it was to get this independent medical examiner who would look at overdose deaths, and this was specifically for prosecution. I would argue that the information could be used as well for surveillance activities as well. But the intention from Christine was it's a very expensive to get these reports done, and people are waiting to get their cases to go to trial because they are waiting on the results and they are waiting on the reports. So and Shayla, if you remember anything else about this presentation from Christine, please add in, because I don't want to speak for Christine, but in lieu of the fact that she's not here, that is my recollection of what she presented.
Shayla Holmes for the record. I have nothing to add to what Dr. Kern's recollection is. I recollect it very similarly.
Okay, thanks. Look, I think this is an example of a demonstration that these aren't mutually exclusive issues, right? We talk about harm reduction, and this can certainly be helpful for those who are in that space to know what's killing folks. But there's also a public safety component as well, which is ostensibly the reason why Ms. Payson brought this from her perspective. So, I think it's just another example of how this committee has a cross sector of interest in determining what's going on out there in the drug arena.
I think staff just has guidance for the break for what.
Okay. All right. So is that the final question?
Yes.
All right. Here's what we're going to do because your chair needs a break. So we're going to take a quick break, but there's some instructions for the break, and then we will come back and finalize all of our good work and go from there. Go ahead. Who's giving the instructions?
Kelly.
Go ahead, Kelly.
So Kelly Marshall for the record. So I would just point the SURG committee members to that document, which is the summary of recommendations. It has a summary of all the draft recommendations on pages 1 and 2. And as you're luxuriating in your break, I would just encourage you to be thinking about which of these recommendations you would identify as your top 5. So that when we get to the Slido polling process, you can easily just match it to what's on your page with the 5 that you want to elevate. And we understand that all of the recommendations are important, but this is a way for us to help start the prioritization process. Thank you.
Thank you so much. And great work, y'all. This is good stuff. I appreciate y'all's work on this. All right, so it's 10:55. Let's get together at 11:05, everybody. 10-minute break. See. Okay, welcome back, everybody. We have a hefty bit of work to get done in 54 minutes. So let's move on to agenda item number 7, a review of the Slido process and complete ranking exercise for preliminary prioritization of SURG recommendations. After this, we'll need a small break to allow the tally to take place. But with that, I guess I should I read the annotation?
Crystal can take
All
it from
right,
here.
go ahead, Crystal.
Okay, thank you, AG Ford. Crystal Duarte for the record. I'm going to describe the process to use Slido to rank your recommendations. Slido is an online application. It's also available on smartphones. And ranking is only available to SURG members. So if you're a member of the public or you are a member who has not yet taken your seat, please do not vote at this time. If you do so, we will have to start the process all over again. Slido is going to make our votes visible, member votes visible. At the next meeting, we will be able to share how members individually voted. Today, what we're going to do is be able to show you the top recommendations so that you can determine if you'll be moving them forward, moving them back to committee, and whatnot. So you're going to be, in a second, I'm going to share the Slido page and you'll see a QR code. And you can scan that QR code to bring the poll up on your phone. You could also go to slido.com and we can enter that into the chat. And you'll enter a specific code that you'll see on the screen. And I'm not sharing that yet just so we can go through all of the steps. You're going to be asked to enter your name and click agree to use my profile details while using Slido. That's so that we can see your names. We can ensure that it's only members that voted and so that we can make your votes clear to the public. And Slido is going to allow you to select your top 5 recommendations. It's sort of a 2-step process. So you'll see a long list of recommendations. You'll go through and click on the 5 that you want to be in the top 5. And then you'll go to the top of your screen and you can move those in the order in which you would like. If you select a recommendation that you do not want, if you accidentally select one, just click on it again and it'll send it back down to the list. And you'll be able to select another recommendation. The system will tell you that you don't yet have 5. So I think you do have to select your top 5. So you would put your number 1 recommendation in the top spot and your last priority recommendation in the number 5 slot. On the screen, you also won't be seeing the full text of the recommendations. Slido has a character limit. So we had to cut those recommendations off. So if you aren't sure that you've selected the right recommendation, please refer to that handout that Kelly mentioned that has all of the details. So let me just double check. Yes. Okay. So now I'm going to share my screen with the Slido poll. So if you're now seeing that, you should be able to use the QR code or go to slido.com and enter 3719445. Staff is available to assist, and if you need to get our attention for assistance, it's okay to chat that. Please just don't chat anything related to how you were ranking. And I would take any questions on the process. It looks like people might be busy prioritizing recommendations.
It looks like Debbie Nebler has her hand raised.
Yes, I'm sorry. I'm working off of my cell phone and I'm trying to get into slido.com. Oh, maybe because I didn't put the hashtag before the 3719445, it's not letting me in.
Debbie, I think it would be easiest if you used the QR code. Are you familiar with how to do that on your phone? So you would place your camera over the QR code on the screen, and that'll take you automatically there.
How can I play if I am using my cell phone? Sure, how to only have one device, my cell phone, which I'm on right now.
Yeah, you should be able to just minimize your screen. What you need to do is either bring up your phone and take a picture, which you can do while you're on the phone, or you can go to a browser like Google and put in slido.com and hit enter, and then you would type in the numbers.
Yeah, they're not coming in, but I think because I didn't put the hashtag in front of it. Do I need the hashtag? Is that why it's not letting me join?
Probably. Yeah, I would try that if you're seeing that as a difference. The other thing that I believe would be okay to do, but maybe Rosalie, you could comment on this, is if you need to just manage doing the poll, you could possibly leave the Zoom and come back. I don't know if that would be okay, but I do understand it might be
Got it.
difficult.
All right. It was the hashtag I was missing. Thank you.
Thanks, Debbie. You knew it. Good job. I believe, Emma, we're looking for 10 responses to the survey or to the poll. So I'm going to give that time and go off camera.
And we can see that some people are ranking. So it may be that once you have completed yours, if you wanted to raise your hand to indicate, although that won't be helpful if you have a question. So if you could somehow let us know, maybe just unmute and let us know when you're done, we'll track it. And just a reminder again, Kelly Marshall for the record. So you are ranking your top 5. So we understand that they are all important, but this is a way for us to get to prioritization.
Assemblywoman Thomas, I see you have a question.
No, no question. I thought you said that you wanted that acknowledgement after you finished.
That is super helpful. Thank you.
I see 8 people have completed it, so I do think we're waiting for 2 more.
Hey, Crystal, this is Eric Schoen. Can you just verify that mine went through?
Let me double check if there's a way for me to see that.
You may not be able to. It's okay.
Crystal, we could probably take a look at make sure all 10 do come through with the right names with our little break after we get everybody in.
Yeah, we'll have to do it that way, Eric, because I can't see names as they're coming in until I export the poll.
Okay.
But it does show we now have 11 people that have completed the poll.
There should have been 10 because one was going to abstain. So we'll have
We'll
to see
double
for
check that
that.
too.
I'm sorry,
I'm
what?
sorry. This is Debbie Nadler. Did you get mine? I think I sent it.
We think we did,
We have
Debbie,
to wait.
because we have sufficient numbers, but we're
Okay, thank you.
figure out
Thank
who
you.
the 11 people are.
I'm gonna take a quick look because it doesn't appear that anyone is continuing to take the poll. So before we go to our break, I'm gonna just check the export and make sure we have everybody that intended to vote and then send you to a break. So that we can do some other magic in the background. I'm gonna read off who I have that voted. Terry Kearns, Eric Schoen, Nancy Lindler, Shayla Holmes, Clara Thomas, Jessica Johnson, Chelsea Cheatham, Lisa Lee, Steve Shell, Debbie Nadler, Jeffrey Iverson. That appears to be correct, and it does not include any members of the public. So I think we are good to take a break. Chair Ford, probably a 5-minute break.
Just to be clear, did Claire Thomas, did you mention her name?
Yes.
Okay, very good. I wouldn't be
Thank you
certain I
for
heard
that.
that. You need a 5-minute break? You got it. We'll see you guys at 23. 18, 19, 1, 2, yeah, 23. All right. All right, thanks so much. Appreciate your work, Crystal. I think you still got the mic, so go ahead.
Okay, this is the poll results. Hopefully you're seeing that. It's an Excel document. Let me try to make it bigger. I think the plan for this section, Chair Ford, was for us to go through and actually, Laura, maybe you could better describe. I think the top 20, we were going to go forward as a consent agenda, and I have a column added here to note a next step for any of these items that the members would like.
So Crystal, it's not that all 20 would go forward as a consent agenda. It's for the members to determine of the top 20, which ones do they want to go forward on a consent? Which ones do they want to remand back to the subcommittee? Which ones do they want to save for next year? Which ones do they not want to do anything with? So that's just of the top 20.
Okay, so I think we got it. We have 27 minutes left in this meeting. I'm not certain that, I don't know if there's enough time or not, but we allocated 30, so let's see how this goes. I don't even know how best to do this. Would you start number 1 and move all the way down? And see, and take a vote on what to do with these?
Yes.
All right, number 1 says, expand Medicaid billing opportunities for preventive services, and allow blended and braided funding to facilitate services to expand access to care for youth and adults. And so again, the options are move forward, as in the December meeting consent agenda, remand back to subcommittee, assign for future action, or assign no further action. Thoughts? Do I got to vote on all of these? Do I have to? I probably need to, don't I?
Yeah, I mean, if we need to break a tie or anything.
Okay, all right. How about this? Is there anyone opposed with moving number 1 forward to the December meeting? Okay, moves forward. Number 2, expand access to MAT, Medicaid-assisted treatment and recovery support for substance use disorder, limit barriers to individuals seeking treatment regardless of the ability to pay, and encourage the use of hub and spoke systems as well as recovery support, including the promotion, blah, blah, blah. I mean, it's just that. So I will ask the same question. Are there anyone opposed to moving this forward to December? Very well, moves forward. I'm not trying to rush y'all, so do feel free to jump in even after I say move forward if you think you need to have a discussion on it. The number's off a little bit.
Yeah, because it says poll option.
All right, number 3. All right, it says number 3, but number 4. Okay, got it. Okay, number 4. All right. Establish a statewide initiative for community drug checking that incorporates qualitative and quantitative drug checking and includes the following parameters. And those parameters were laid out. So same question. Anyone objecting to move that forward to December? It goes forward. The next is increased support for harm reduction based on post-overdose outreach with public safety, including wraparound services for surviving family members and/or post-mortem services for families. Objections to moving it forward?
Wasn't there a recommendation to take this one and put it with one of the response, RS3, and rework those?
So for RS3, that's what this one is, right?
This is HR3.
So HR3, and it was suggested HR3 and RS3 be sent back to the respective committees for workshopping and try to combine those.
Which subcommittee should take the lead on that?
Wasn't the agreement they would work together? Can the two work?
I mean, you can have a joint meeting just like you have joint meetings with the ACRN.
Okay. So based on, I'm sorry, someone's gonna say something? Jessica?
Chair Ford, Jessica Johnson, apologies to interrupt. I just noting that this is a harm reduction recommendation that does not currently have a subcommittee and was the expanded effort from the prevention subcommittee. So happy to work collaboratively with the response subcommittee as the chair or designate an affiliate for discussion, if appropriate, to the committee.
Response will take lead.
Okay, so then response will take lead on this. Yeah, there we go. Remand back to subcommittee with response taking lead. Okay. Jessica, I'm sorry, Lisa, did you have your hand up or are you good now?
Thank you, HE Ford. Lisa Lee for the record. I just was a little bit confused regarding the difference between the count and the ranking, but I think I figured out that it was because the multiplier, it was weighted. And so that kind of categorized them differently. So I think I figured it out. And I see Crystal nodding her head. So thank you.
All right, thank you. The next one is about providing support to community coalitions to support community health workers to expand harm reduction throughout the state of Nevada and prioritize funding for community health workers to provide community-based harm reduction services. Objections to moving it forward?
Hey, Chair Ford, Eric Schoen for the record. No.
Yes.
No objection to moving it forward. I'm wondering though, if there's a way to combine this recommendation with the next one, because they both are talking about expanding community health workers and peers to be a more involved integral piece of the workforce delivering these services. So I'm wondering if we can't combine these next to that recommendation somehow.
Okay. So HR was harm reduction and TRS was treatment recovery. This will require a remand, I guess, then to a subcommittee to, now, which committee wants to take the remand? I guess it doesn't matter, right? Because they're gonna do a
It could
joint
be
meeting. Right?
either prevention or treatment and recovery.
It was prevention?
Well, prevention worked on the harm reduction.
Oh, got it.
There isn't a
Oh.
harm reduction.
Jessica has her
specifically.
hand
That was the
raised.
whole.
Jessica?
Thank you, Chair Ford. Jessica Johnson for the record. Again, if the treatment subcommittee is open to taking this, that would be really helpful from a harm reduction recommendation perspective, and perhaps the prevention subcommittee can send a representative to just speak to the workshopping history, if appropriate.
Sounds like a plan. Okay. I'm gonna let her catch up on that. Okay. The next one is recommend to DHHS and TPVH, the Bureau of Behavioral Health, Wellness and Prevention, to double the amount of investment in primary prevention programming for every 2 years for ages 0 to 24 and review the funding allocations annually. I've stated my comments in that regard. I think it should be refined. But, you know, let me hear what y'all have to say.
Assemblywoman Clara Thomas for the record. Excuse me. Thank you, Chair. I'm going to agree with you on that because it depends on what fiscal note comes into play. So I wholeheartedly agree with you.
Yeah, my suggestion is that we remand it back. And I know that Jessica said there is a 20-year-old outdated study that deals with this, but if that's the best we got, it's the best we got. But I think we have to put some numbers to it, especially if you intend for the legislature to act on this. They're going to require more than a qualitative request that we need 2 times as much as what we currently got. So let's remand that back to the subcommittee for additional work.
Debbie and Lisa have their hands raised.
All right, let's go with Debbie and then Lisa.
Thank you. Just going through all of these, I'm going to again state just for the record, this is Debbie Nadler. They're going through all of these and everything is important and we all know that, but there is nothing on here for primary prevention. And it's so very important that it goes on these poll options somehow that we send forward. I don't see anything in here on primary prevention. If there's something that we can push forward that relates to primary prevention, is it for the schools, for the kids, for the public? I don't know if we can meet back again, add this back on there, but I think it's the utmost importance. And I'm seeing nothing on primary prevention.
Hey, Debbie, let me have Dr. Kearns respond to you real quickly. Maybe this will satisfy you for the time being.
Yeah, Debbie,
Thank
this
you.
is not to say that the primary prevention would not move forward. What it's saying is it needs to go back to the subcommittee to have it reworked a little so it can be considered again for the December meeting.
Oh,
The
okay.
December
Thank you.
surge meeting.
Okay.
All right. Thank you. We had another hand up.
Lisa.
Lisa, go ahead.
Thank you, Chair Ford. Lisa Lee for the record. I would agree with you that it needs some refining. Typically, primary prevention is very well funded. And so I think maybe this is where the funding mapping that was conducted by DHHS might be helpful to sort of kind of look at which funds have been allocated across the state. Again, thinking back, oh gosh, several joint task force meetings ago at how the allocations across prevention, treatment, and harm reduction. I just want to give a plug for harm reduction. It was $140,000 statewide that was designated to harm reduction, and harm reduction efforts are typically well underfunded. We have to go after some pretty crazy funding sources. And so I would argue that primary prevention is pretty well funded, and those maps might come in handy for sort of a targeted discussion of what already exists and what the needs might be.
Yeah, no, thank you. Again, you've articulated that much more eloquently than I could have. And so I think we are in agreement that's going back for additional work.
Jessica and Debbie have their hands.
Jessica, and then we need to kind of keep going, guys. We're running out of time. Go ahead, Jessica.
I just wanted to thank the search committee for your comments. Our committee will work to incorporate both the cost effectiveness and some of the funding maps from previous presentations into this recommendation as we bring it back forward in December. Thank you.
Thank you. Debbie, real quickly, please.
Thank you, Jessica, for bringing that up. Again, I will state there is so much being done in Northern Nevada that is not being done in Southern Nevada. And I'd like to bring that up in the next meeting, or Jessica, perhaps in our meeting. We don't have the resources in our schools. We do not. I'm on a board with over 100,000 parents of Las Vegas and Henderson. And if somebody could go in there and look at the comments about drugs and their kids and what to do, they know nothing about it. It's so important that we concentrate on primary prevention as well as everything else.
All right, thanks, Debbie. All right, moving on. Support harm reduction through making a recommendation to DHHS to utilize opioid settlement dollars to designate a baseline level of identification and overdose reversal medication for the next 10 years in Nevada to create a stable, sustainable source of overdose reversal medication throughout the state. Any objections to that moving forward? Hearing none, we'll move forward. The next is establish priority funding areas to ensure entry into treatment and or recovery, ensure that Black, Latinx, Hispanic, Indigenous, and people of color and LGBTQI communities are receiving culturally and linguistically appropriate overdose information. I suspect. Same question. Questions about this moving forward? Any suggestions on an alternative? All right, let's go. TRS5, significantly increase capacity, including access to treatment facilities and beds for intensive care coordination to facilitate transitions and to divert youth under the age of 18 at risk of higher level of care and or system involvement. Any objections to it moving forward? As a reminder, this is going to run parallel with litigation solutions that are currently being discussed. Away it goes. Next one is RS3. I have HR3 as a note listed here.
Yeah, that's the one we said earlier, that HR three and RS3 need to go back to subcommittee.
Got it, okay.
To the response subcommittee.
Got it, okay. Next up is the PS7. Support harm reduction through implementing changes to recruitment, retention, and compensation of health and behavioral healthcare workers and enhance compensation in alignment with the Commission on Behavioral Health Board's letter to the governor of June 22nd, and also to continue to sustain and expand investments in community health workers, peer recovery specialists, and certified prevention specialists by implementing changes to recruitment, retention, and compensation. All right, let it go forward. The next relates to tobacco, PS2. Allocate tobacco control and prevention funding using local lead agencies model to reach $2 per capita recommended funding using a combination of funding sources. I think this probably should go back, and I'm gonna tell you why. I wouldn't mind having some of my tobacco dags sitting in on a meeting with this subcommittee to talk about the intricacies of this type of matter, because there are certain rules related to tobacco funds and things of that sort. So let's send that back to prevention, please. And if you want to have an additional DAG, and if y'all decide that you don't want to talk about this, then we can do no further action. But I think you need to have a tobacco DAG talk about it.
I forwarded it to the tobacco tag already.
Like today?
No,
Oh,
previously,
oh,
just for her knowledge.
oh. Did she have a response? All right.
No, I
Okay.
just for her information, so I can reach out and let her.
Yeah, let's find out. Let's vet it just a little bit more so that I can feel confident that we can do something that's suggested here. All right, HR 4.
Debbie has her hand.
Oh, I'm sorry. Yeah, Debbie, go ahead.
Thank you. I agree with you, Attorney General Ford, but I had another thought. If I don't know why we're not adding marijuana to that. I think we had discussed it before, and somebody was supposed to get back to us on the numbers of the marijuana users as well. Just my thought on that.
Well, I can respond initially to this about tobacco. It's because tobacco taxes and the master service agreement and the settlements relate to tobacco only. You can't utilize those funds for marijuana-based things. And so this particular recommendation relates to tobacco. You may have a separate recommendation for marijuana, but it can't fall under this one. With that, Jessica, go ahead.
Sorry, having trouble unmuting. Jessica Johnson for the record. Two quick points. Yes, the prevention subcommittee has been working with the experts doing marijuana or cannabis prevention education to get a time scheduled, and haven't been able to identify that as it relates to the prevention subcommittee schedule yet this year. So that's currently in progress for our subcommittee. And additionally, this recommendation does cover vaping prevention as a mechanism that is used for a variety of substances, including tobacco. Thank you.
Yeah. To be clear, though, vaping for tobacco stuff would be covered, but vaping, the marijuana coverage is nebulous to say the least under this particular provision. Okay, the next one is to create a bill draft request at the legislature to change the language around drug paraphernalia as it relates to smoking supplies. I think it's too vague. That's just what I think. I don't know if Assemblywoman has any position in that regard, but I think it's too vague. I wouldn't be able to take that and run a BDR on it.
Totally agree. Assemblywoman Clara Thomas for the record. Totally agree, Chair.
Okay. My suggestion is that we remand it back for them to maybe reword it, give us a little more details on what we're talking about here and kind of go from there. The next one is support harm reduction through creating a recommendation to the legislature model on Maryland's STOP Act, which authorizes certain medical services providers to dispense naloxone to individuals who receive treatment for non-fatal, et cetera. Comments? So I'm not necessarily opposed to this going forward. I would like more information about Maryland's STOP Act, however, in the context of this moving forward, because it sounds as though this would likewise be a BDR of sorts. But the fact that it references an actual act gives me a little more comfort in saying it can move forward. Does anyone have a thought on it besides that?
Jessica has her hand raised.
Yeah, Jessica.
Thank you, Attorney General Ford, Jessica Johnson for the record. So some of the language that is included in this authorization is adapted from Maryland STOP Act, and that the information on the STOP Act specifically is provided in the references for this particular item. That of course doesn't mean that this the language couldn't use improvement, but just wanted to share that the research is available in what was provided to SEI and the Prevention Subcommittee.
Yeah, very good. Thank you. So let's move it forward. Okay. Where am I? All right. PS3. PS3 recommendation to DHHS to create a data dashboard or other type of regularly updated report on alcohol outlet, tobacco outlet, and cannabis outlet density. David, this speaks to cannabis, so this might touch a little bit on what you were asking about.
Yes, thank you.
I hear no objection to it moving forward, so it'll go forward. Okay, the next one is HR 2. Harm reduction shipping supply. Provide travel costs for pickup of used products to be returned for destruction. Increase advertising about shipping programs and establish alternative strategy if people can't receive delivery of the supplies. Comments?
Jessica has her hand
All
raised.
right, Jessica.
Thank you, Jessica Johnson, for the record. My recommendation is to remand this back to the prevention subcommittee, and if there is a SURG committee member who is willing to complete the qualitative sections for this particular recommendation, that would be really helpful for our subcommittee. Thank you.
You did say that, so point taken. I think it should go back per your suggestion there. Claire, you had a question?
No question. I was in full agreement with Jessica, and that's Claire Thomas for the record. So no additional remark. Thank you.
Thank you. TRS 3. Oh, Chelsea, go ahead.
Yes, hi. So that's a program that I actually helped run at Track B Exchange, the harm reduction shipping supply. So I wouldn't mind taking on doing the qualitative section for that.
Very good. Thank you for jumping in on that. TRS 3, right? 3?
Yes.
All right. Implement a specialized child welfare service delivery model with follow-up and referral and linkage to care that improves outcomes for children and families affected by parental substance use and child maltreatment in pregnant or birthing persons with opioid use disorder. Yeah, look at something right quick. It's page 47. Lisa, I'm glad you're staying on because this, I think this is kind of up your alley and we need you to kind of stay engaged and involved on helping this if it moves forward. You cool with that?
Yes, sir.
Did we lose? Okay, all right, thanks. Let's let it go forward then. And then the evaluate current availability, let me read it here. Evaluate current availability and readiness to provide comprehensive behavioral health services to include but not limited to screening, assessment, treatment, recovery support, and transition for reentry into local and state carceral facilities. There's more there, but that's a good summary. Thoughts? Okay, let it go forward. It seems to me that these other ones have zeros. So do we have to consider them? That means nobody voted for them, right? Okay, all right. I'm waiting to hear somebody tell me otherwise.
My only comment is you had to vote for 5, so that doesn't mean
okay.
that someone may not still support
didn't rank
it.
it as
It
top
just
5.
didn't rank in their top 5. So I would suggest they still,
Be considered.
yeah.
Okay, well, let's go through them. Implement follow-ups and referrals and linkage for of care for justice-involved individuals, including individuals leaving the justice system. I mean, it seems to me, let me hear from y'all. Go ahead.
If I remember correctly, there was a recommendation that treatment and recovery number 2, which you just read, be considered with RS1, response 1, which is right above it. So I think it's to go back and rework these and combine them.
I think that's right. And so which committee is going to take the lead on that? Which subcommittee? TRS and the other is recovery?
Recovery. recovery can with,
All
with the support of someone from treatment and recovery.
Okay, all right. Good, thank you. The next relates to the wastewater issue.
Sheila has her hand raised.
Shayla?
Shayla Holmes for the record. I would, I'm curious, so with some of these items being perhaps reworked to be consolidated, if there's not then room for some of these other items to be moved within the report, that might not change the voting in the future. So I'm not sure how we're dealing with that, but this is certainly one that I would like to see move forward. While it might not have ranked with some of the other items that I think are critically important, I do think this is an important item. So I don't know if we need to bring it back next year to be voted on again, or if there's room with some of these consolidations for other ones to be considered, not just this one, but perhaps some of the other three as well.
Terry, you want to say something?
Sure. Shayla, it was my understanding that even though these did not receive any votes, because all of the surge members had to just pick their top 5, that they could still be moved forward in the report. Does that make sense?
That does make sense. I know other folks have their hands up, but Shayla Holmes, for the record, I would encourage this to move forward into the report.
Okay, who's next?
Jessica and Lisa.
Jessica and then Lisa.
Ms. Lee, I believe you had your hand up first, if you'd like to go first.
My bad, Lisa.
Thanks, Jessica. Lisa Lee for the record. Real quick, I feel like the language, I agree with the spirit of this recommendation. It's the language. What does that mean? Understand the true cost. Who is doing the understanding? How is the understanding being accomplished? It's not really a directive on how we're going to get there. What does it mean to understand the true cost? Could it be reworded so it's direct such and such agency to conduct a feasibility study on to better understand? Like for me, it's too vague at this point. I mean, I understand the spirit of it, but I'd like it to be narrowed down, similar to some of the legislative asks where it just needs to be fine-tuned a little bit. What does understand mean? And how do we get there? Who is doing the work? That's what I'd like to know.
So Shayla, you're amenable to, if we send this back to the committee, i.e. don't kill it, but send it back to the subcommittee and rework it a little bit and maybe hear back from Lisa on specific questions and maybe we can get it, bring it back. Let's do it that way.
Shayla Holmes for the record, I am certainly agreeable to that and appreciate the feedback.
Thank you. All right. Where am I? Okay. RS4. Review the operations and lessons learned from Clark County's overdose fatality review task force when that body's report is released in December of 24, and take into an account on supporting legislation to establish a regional overdose fatality review committee. I'll just say that I think we should send this back. We could wait for a little bit because the report's not out and you're talking about legislation, which won't happen until 25. And so my suggestion is that we just send this back. I don't want to kill it. So a remand to committee is I think the appropriate thing, but I'm not sure there's much for the committee to do at this juncture. Unless someone disagrees. I see a hand up. Lisa?
Thank you, Chair Ford. Lisa Lee for the record. I just want to remind this body that there was an opportunity to, this was in the last legislative session, Doctor, he is a doctor actually, Dr. Assemblyman Orentlicker pushed forward an overdose fatality review board piece of legislation that was, it did not turn out the way it started. I'll just say that. It was heavily amended. And so where was the support then, is my question. And is there an opportunity to look at the bill that he pushed forward at the beginning of the session, not the one it turned into, which I think is the Clark County opioid task force. That doesn't have anybody that's, again, like ground level on that breakdown of the committee. So that's problematic, but is there an opportunity to sort of look at the bill that he pushed forward and refine that? I just feel like that was an opportunity lost.
Yeah, I mean, it's to my point of this going back to subcommittee, right? Because maybe the subcommittee can bring in Dr. Orlinger and ask him what went down. And we could do some other additional work in that regard. So let's send that back, please. Again, I don't know how soon you have to work on it because we got a little time yet. I just don't want to kill it by saying no further action.
And just to Terry Kearns, for the record, just for background, this was a recommendation from our last annual report. So it was a moving forward of a prior with some amendments, but response will look at it.
Okay. And then on this last one, understanding what coroners and medical examiners currently test for, to my comments during that discussion, I think maybe an opportunity to hear from coroners, if there is a state coroners board or association. We talked about maybe them being able to commit to that report to that subcommittee. So my suggestion is that we send that back as well.
Lisa has her hand raised.
Lisa?
Thank you, Chair Ford. Lisa Lee for the record. I just want to say on record for this one, I fully do not support if the intention is further criminalization. Overdose it's awful when it happens. I understand, you know, how controversial it can be, how people just want to do something, right? I understand that. However, furthering the war on drugs is going to make people lose trust in the Good Samaritan overdose law. And so until there's further discussion around the tension between the drug-induced homicide law and the Good Samaritan Overdose Act, I just want to voice my opposition to this as it is intended. Thank you.
I appreciate that. And I will simply say this committee is comprised of harm reductionists and law enforcement, as evidenced by the fact that I'm the chair and I'm a law enforcement and you're vice chair and you're a harm reductionist. That's by design. So we need to ensure that we are taking into consideration the various viewpoints here, notwithstanding the fact that at the end of the day, it's going to be a committee decision on how to proceed. So I support looking at this from both angles, harm reductionist and from law enforcement, and would support it once we get more information, I think. So regardless, it needs to go back for additional consideration, it sounds like.
And Jessica has her hand raised.
Jessica, go ahead.
Thank you, Chair Ford, and thank you, Ms. Lee, for your comments. I wanted to echo that I have concerns about supporting this as currently written, specifically with an independent medical examiner, primarily for prosecution. It's documented that our coroners and medical examiners in the state do not receive adequate funding to be able to scale up the investigations as needed right now in terms of doing expanded panel testing. So I would recommend for the response subcommittee to learn more about the funding caps for what currently covers these types of medical examinations in advance of any funding for any type of independent person. Thank you.
Yeah, thank you, Jessica. And Mr. Shields, I think you might be interested in this conversation as well. So I'd ask that you avail yourself of any subcommittee meeting that takes place on this issue so that we can glean information from that side of the issue as well. Okay, with that, I think we have completed that particular task. We are a little behind schedule, but we're almost done. And thank you all so much for the hard work on this, and thank you for the vigorous discussion back and forth. Let's move on to agenda item number 9, which is a review and consideration of items for the next meeting. Dr. Kearns?
Yes, so as you can see on the slide, the areas that we have outlined for the agenda for the December 13th Surge full committee member meeting are to finalize our recommendations to be included in our Surge annual report, which most of you will remember is due at the end of January 2024. So we'll then review the outline of that Surge annual report. I have a presentation from DHHS as per the legislation from their annual report to report out to the Surge. An update on the opioid litigation settlement funds and distribution by Mark Kruger, and then talk about our proposed 2024 meeting dates and times for the Surge. And one other item that, it is on here, reappointment, new appointment of Surge members will also be discussed. We have 8 committee members whose terms will expire on 1/1/24.
Okay. Any comments, suggested additions to this for now? Debbie.
Hi, thank you very much. I think I stated it in our last meeting. We've all invested so much of our time, and everybody has been so wonderful on this committee. How do we stay on the committee, especially when we all have ideas and recommendations that we've talked about for 3 years, and then all of a sudden have to give up our term to pass it off to other people when we've had this wealth of knowledge come pouring into us over the past 3 or 4 years. How is that going to work if we want to stay on?
Debbie, I appreciate your concern. I've heard the same thing about term limits, for example. Turnovers with all the knowledge leaving the room. I'm not certain I have an answer for that, Debbie. But your question is duly noted, and we'll think on that.
If I can add, Debbie, I would just add, Terry Kearns, for the record, that as you can see, it's either reappointment or new appointment. Some people like yourself would like to stay on, but there's others who have other commitments or change jobs, and those that can't. So those are items that will be considered as well.
Okay, thank you, Terry. Thank you, Attorney General Ford.
You're welcome. Okay, any other questions on this agenda item before I move on to public comment? All right, hearing none, we will open it up to public comment again. Anyone here in Vegas for public comment?
Giuseppe Mandel, Desert Hope, American Addiction Centers. First of all, thank you guys all so much for the rigorous work that you all do. The state, I think, has made strides in the last 3 years. My main job in the community is to work with all the different facilities, whether it be hospitals, jails, institutions, judges, attorneys, anywhere that would get people into treatment. So I appreciate all the information. I just have just to give you guys any information of what I'm seeing on the front lands lately. And Lisa, sorry to hear you go. I would love to get with you off the record at one point to collaborate what you're seeing up there to what I'm seeing down here. But one of the things I am seeing, and I think we're making great strides in, is going towards harm reduction, but bridging that gap to where in treatment I'm having a hard time getting people treated that say are smoking, say meth, or not necessarily injecting heroin. I know we're going harm reduction, people are going towards smoking, and it's awesome, and we're making huge strides. The thing is, can I get them treated once they get to my facility? Can I get insurances to pay for that? Or if I have incarcerated individuals, with a lot of these suggestions, if we put that money towards that, say we've got money towards incarcerated individuals, can I get them treatment if they've been incarcerated for only 2 weeks and I can't get an insurance to Medicaid or private insurance to pay for treatment to get them into treatment because of criteria? So I don't know if this is the right meeting, the right suggestions. I'm just saying what I'm seeing on the ground level. Good news is a ton of people are getting help, all due to a lot of the work that you guys are doing. And I think we're making huge strides in there. But just a couple of the questions of going that forward. How would we do that portion of it to kind of bridge that gap to where, we focus a lot of money and funding towards and recommendations towards harm reduction and those things, but are we gonna be able to treat them if we go that route?
Okay, all right. Thanks for your comment made out loud, duly noted, and folks who are responsible for putting together agendas might be able to respond accordingly. Okay.
Thank you, sir.
Any other comments down here? How about up in Carson? Any public comment in Carson?
No public comment in Carson.
Any public comment on the phone?
Debbie Nadler has her hand raised.
All right, none on the phone. Let's go to the screen then. Debbie Nadler.
I'll make this short and sweet. I just want to thank each and every one of you because I came in here with blinders on 4 years ago, and each one of you has opened my eyes so intensely on everything. And I have so much respect for every one of you. And I want to thank you from the bottom of my heart, truly. Thank you.
Well, that's nice. Made me smile. Thank you, Debbie. Anybody else for public comment?
Yes, sir. Oh,
Just
Rick
a
had his
second.
hand raised and then it went down
Hey,
again.
hey, Rick, your hand was up and then it went down?
It's up now.
All right, Rick, go ahead. It came back up, went back down. Okay, going once, Rick. Going twice?
There we go.
All right, go ahead, Rick.
This is Rick Reich in Las Vegas, Nevada. I'm with Impact Exchange, and we're the only harm reduction agency that currently is doing syringe exchange. We do that either in a storefront or, of course, in our vending process. I would like to just stress one thing. I think that you guys have been very thorough in all of the items that you touched on here and your recommendations. But one thing about harm reduction that I would like to point out, and I keep trying to state this in the community, is that when it comes to interaction with people who are using illicit substances, the criminal justice system sees them infrequently. The treatment modalities that are available have to get them sort of referred one way or another. They either have to walk in or be referred by some other agency. And thirdly, the emergency departments, which we were actively involved with up until recently, could be a source for people when they overdose. All of those are limited, though, to that particular interaction. When it comes to harm reduction, and especially supplying clean syringes and safe devices, you see these individuals almost on a weekly basis, every week. So whereas criminal justice may see them 3 or 4 times a year, we may see them 52 times a year. And so the impact that we can have upon an individual in helping them make some life changes in terms of the process of where they go down the road, whether it's further into addiction or into treatment. Obviously, we have a little bit clearer, shall we say, contact point with them in terms of frequency. And I would just like to make sure that people understand that harm reduction isn't a one-time interaction. It's a thorough, almost weekly, if not even more frequently, contact with individuals, supplying them with clean devices and with information, education, and offers for treatment and testing for other diseases. And I would just close with that. And thank you very much for allowing me to listen in on all of this.
Thank you so much, Rick, and thank you again for your work. Okay, last call for public comment. Hearing and seeing none. Everybody, we are adjourned. Thank you so much. See you next time.
Thank you.